So thank you. From the infections, we're going to turn to minor head trauma with special considerations. So the objectives of this next 30 minutes is to talk about the best available evidence to guide the management of a child with minor blunt head trauma. We're going to talk about different approaches to neuroimaging. We're going to talk about validated head trauma clinical prediction rules, and then to look for the role of observation in the management of children with isolated head injuries. So this figure here looks at the number of emergency departments to US centers for head injuries. This is not just for children, but also for adults. And on the x-axis, you have time, 2006 through 2010. And the filled in circles are all ED visits. And the open circles are visits for traumatic brain injury. And so what you see here is that over this time period, there was a slight increase in the total number of ED visits, but a dramatic increase in the number for head injuries. This does not reflect probably an increase in actual number of head injuries, but the level of concern of the parents and the patients around head injuries. And so what we're seeing is an increase in this complaint in our emergency departments, but we're seeing a lot of not very severely injured children. So the challenge for the clinician becomes, how do you find those with clinically significant traumatic brain injuries, but also at the same time limit unnecessary imaging tests? Significant injuries are rare. The diagnostic tests that we do, which is mainly CT scan, and we'll talk a little bit about that, have some risk of radiation. And so what we need are tools to stratify infants and children that help us and guide that decision making. So we'll look at the types of studies available to us in the emergency department, which are essentially skull films, CT, and MRI. So skull films are actually a series of 4 films. I've shown 2 candidate images here. They're easy to obtain, but their interpretation is challenging. So if you're not familiar with looking at skull films, it's hard to see, is that a fracture? Is that a suture? And importantly, there's no evaluation for intracranial injury. So if you see a fracture, which is what you're looking for on a skull film, you don't know if there's an underlying injury very commonly for that very reason. CT is the gold standard and the most common approach to the evaluation of children, but there are some risks of CT scans, and those are risks of malignancy down the road. There's some debate of how high that risk is, but the best estimates are approximately 1 in 1,500 if you're 1 year old when you have a head CT scan. And there's some variability about how much radiation and how much dose adjusting the actual scan entails. But if you're older, it's probably 1 in 5,000, so a lower risk as you get older, which reflects both the cells in an older child are not dividing as rapidly, and you have fewer years of life ahead. But those numbers, although small, put in a different perspective. The lifetime risk of malignancy worldwide is about 24%. About a quarter of all deaths are from malignancy. And so having a single CT scan is going to increase that from 24% to 24.07%, which to a parent sounds very different than 1 in 1,500. So it's just sort of an illustration of how you frame risk it affects the interpretation. What about MRI? There's increasing interest. Typically for trauma, you're not doing a full brain MRI for a pediatric patient, but something called a rapid cranial MRI. They're vent check MRI, rapid cranial, and they can be done quickly, so they would be possible for trauma, but there's a limited literature of how good they are at picking up significant injuries. The best study was published in 2019 by Dan Lindberg in pediatrics, and he had a series of 223 children who had both a CT and an MRI performed. And of the 111, which had a positive CT, as was defined in the study, 103 had a positive MRI, 2 had an equivocal MRI, and 6 had a negative. And so that's a sensitivity of 90% and a specificity of 96%. So those that were not identified, those findings that were not identified on MRI were minor intracranial hemorrhage or other findings without needing surgical intervention. But there are findings that we see on CT that we don't see on MRI. And so we need to further delineate that before rapid cranial MRI becomes our gold standard. What about incidental findings? Whenever you do cross-sectional imaging or any type of imaging, you have to be prepared for things you weren't looking for. So these would be findings that are not related to the trauma, but need to be interpreted and followed up on. So if you don't include sinus disease, because if you did a CT on many of us in the room, we might see some mucosal thickening or swelling of our sinuses. This large study of 15,000 CT scans of the head done for trauma found that 4% had incidental findings. Very few of those incidental findings needed immediate management. A few of the children in the study actually had brain tumors identified at the time of their CT for head trauma. But most of them, or a quarter of them, needed some outpatient follow-up, some additional clinical evaluation, and 70% were incidental and no follow-up needed. But it is an important unintended consequences of the imaging studies that we do. Likely, if we do MRI, which is a more detailed architecture of the brain, we may have actually more incidental findings, and we'll have to be prepared for dealing with that. Okay, so if we don't want to do CTs on low-risk patients, how can we decide? We have a really high-quality study led by Nate Cooperman from UC Davis, or the PCARD TBI rules, and I'm interested to hear if they're used here in the Kingdom of Saudi. But this is a study which has changed practice in the US and many parts of the world. Involved 25 sites in the Pediatric Emergency Care Network, and they looked at kids less than 18 years of age with non-trivial blunt head trauma. So the outcome of interest was something called clinically important traumatic brain injury. They didn't want to identify necessarily all intracranial hemorrhage, but rather findings on the CT scan that would affect practice. So what were they looking for? They were looking for children that died from their head injury, who needed an emergent neurosurgical intervention, who were intubated for more than 24 hours for their head injury, or needed 2 or more nights in the hospital for management of their head injury. The study was quite large and enrolled 33,000 children in a derivation cohort and another 8,000 in a concurrent validation cohort. And they came up with 2 rules. They did a rule for children less than 2 years of age and one for children greater than 2 years of age. And the reason why it was dichotomized at 2 years of age is that's approximately when children become verbal or consistently verbal. And so in the youngest children, you can't use subjective symptoms like, do you have a headache or how are you feeling? And so they wanted to examine those groups differently. Also, the mechanisms of injury and the types of injuries are different, and so they felt it was clinically important to look at these groups separately. So the factors included, the 2 high-risk factors are GCS 14, or other signs of altered mental status, or palpable skull fracture. And in that group, that was 13.9% of the population and a 4% risk of clinically important traumatic brain injury. The other 4 middle risk factors were a non-frontal hematoma, an LOC of 5 seconds or more, severe injury mechanism, or not acting right. If you had any of those factors, you were in a middle risk group, which was 1/3 of the patient population and a 1% risk of clinically important traumatic brain injury. If you had none of those factors, you were in a low risk group, and that was more than half of the study population, and the risk of clinically important traumatic brain injury was very low, less than 1 in 1,000. Again, there's 2 rules. The rule for kids greater than 2 is very similar. Again, GCS 14 or other signs of altered mental status or signs of basilar skull fracture. The middle risk factors in the older kids were any LOC, history of vomiting, severe headache, or a severe injury mechanism. Again, you have the middle risk group and the low risk group. How well did this rule do? It did very well. In the concurrent validation, so that's the 8,000 infants that were enrolled at the same time, the sensitivity was 100% in kids less than 2 and 96.8 in kids greater than 2. It did miss 2 children who had fallen downstairs, so they didn't have a severe injury mechanism, but they had fallen down multiple stairs. The severe injury mechanism was defined by the height of the fall, and each stair is a series of smaller falls. So indicating that clinical decision rules do not replace clinical judgment, they supplement it. And so as a clinician, you might take that into account as well. There's been additional external validation studies as well. And Franz Babel from Australia did a very nice external validation, included 15,000 children. He compared 3 available head trauma rules. The one that performed the best was the PCARN rule. And again, it had very high sensitivity and modest specificity in both age groups. So we have this really good rule. The next step is validating it, getting the evidence into practice. We've talked about the gap between evidence in the published literature and actual practice. In the area of head trauma, there's been some good work of implementing this high quality evidence into practice. So how can you do that? One approach would be just to make a guideline and publish that guideline to your practitioners. And that's a very effective strategy and low budget and easy to do. Secondly, you have calculators, and then in a more advanced way, I saw at the Fuzzle Children's Hospital, you use a Cerner informatics system. You could build these rules right into your informatics system so that this evidence was available to you at the point of decision making. So we'll take you through this. An evidence-based guideline is just you get together with your clinicians in your local group or your region or your society, something like the American Academy of Pediatrics, and you say, this is how we should manage children with head trauma. It's best if it's based on high quality evidence like the P-card decision rule, but implementing this type of practice can affect change. Here's an example at my local institution where we implemented an evidence-based guideline. And what we did is we tracked the CT rate over time. A statistical process control chart is a method of following practice change over time when you're doing quality improvement methods. And so we started with a 20% baseline, 21% baseline CT rate. We implemented a guideline. The rate went down to 15% of children with head injury visits. And then we did some individual performance review feedback, and that rate went down further. MD Calc is a widely available application and website which translates evidence-based guidelines at the point of care. I'm not sure if it's used here in the kingdom, but it's widely used in the US where you are reminded of the clinical decision rule. You pull out your phone, you can type in the predictors, and it'll give you an estimate of the risk right at the time you're taking care of the patient. And then the gold standard is actually to embed these implementation tools in the electronic health record. And our colleague, Peter Dayan, did some really nice work in an Epic-based system. This is a BPA or a computerized decision support tool that was built into the computerized system where it asked for the factors that are included in the P-card decision rule at triage. So the nurse that was first assessing the patient collected some information that was then validated by the clinician, and then you were given some decision support, which was really the estimate of risk in that individual patient right at the time you were caring for them. How well did that do? It actually did very well at decreasing the CT rate. So it was done as what's called a cluster randomized study. So there were 4 general EDs and 4 pediatric EDs that were included. One did not get the intervention, and that was called the control hospital. And what this is the dotted line is the time when the computerized intervention was turned on. It was turned on at slightly different times at each hospital, but they had the same period of time before and after. And at the intervention hospitals, the availability of the decision support was associated with a 9% decrease in the CT rate, where there was no change at the control hospital. We have great evidence. We are trying to get it into practice. Is it working? This is a national study looking at head trauma visits to all emergency departments, pediatric and general EDs. And unfortunately, despite all these efforts, it looks like in the US, the head CT rates are relatively constant. So if you look over this period from 2007 to 2015, of all head trauma visits, 30% of children are receiving a head CT, and that's been constant despite education about the risks of CT, the availability of the P-card rules, and a specific education campaign done by the AAP called Choosing Wisely, meant to reduce CT rates. So although there's knowledge, there's tools for implementation, it's still hard to change practice. And so that's why we need to do better in that regard. So with the available time I have left, and I'll trust that I'll be reminded, we're going to go through a couple different cases. So this is where I work. This is the street view. And so these are all children that are presenting to the emergency department. So this is a 15-month-old who fell from the shopping cart. They were sitting in the front. They took a dive over the top. The parent describes there was a brief loss of consciousness. You see a little abrasion and a hematoma in the front, but they're otherwise acting normally. So you would see the child. This child is napping now, but they wake up and they're alert and they're oriented in front of you in the emergency department. So when you see this child, you're going to be calculating the height of the shopping cart, guessing how far they fell. But the definition of a severe injury mechanism is 3 feet or more in a young child. So you're guessing they fell probably around 3 feet from the shopping cart, and they had a brief LOC. So they have 2 of the middle risk factors for a traumatic brain injury based on the PCARN rules, but they look really good in front of you. So what should you do for this particular child? So the clinical decision rule is low risk versus not low risk, but there's really a lot more evidence that we have in terms of the actual risk in the individual patient. And so because the study was large and well designed, there have been a number of subsequent studies that look at the risk at each of the individual risk factors. And so this table, which is available in the individual studies as well as up to date, if that's a reference that you use, if you have one of the PCARN middle risk factors, the risk is still quite low that you have a significant injury, but when you start to have 2 or 3 factors, that risk goes up. So that is to say that if you have one of the middle risk factors, you probably don't need to go ahead and do a CT, but if you have, you start to have 2, 3, 4 factors, and your child doesn't look that well in front of you, the risk becomes higher. So what are our strategies? Observation can be a really effective strategy when you're not sure. The patient's not at low risk, but they have some factors. And that is a simple strategy where you're just going to watch the child and see how they do over time, over the matter of a few hours. And if the symptoms stay the same or worsen, you're going to go ahead and get a CT scan. And if the symptoms improve, then you feel good about sending them home. This can be challenging in a busy emergency room where you have a lot of patient turnover. They don't necessarily need to be in an acute care room. They can be in the waiting room and called back for reassessment. Does the strategy work? And I would say yes. We've done a secondary analysis of the initial PCARN study, and those patients who were observed, because we collected information about clinician practice, had a much lower CT rate. In fact, the adjusted CT rate for severity of injury was almost half in the group that was observed compared to the group that was not observed, but despite a similar rate of clinically important traumatic brain injury. So the strategy works for those that are symptomatic. If you're able to wait, many children with a dose of Motrin, a dose of Zofran look miraculously better in an hour or 2 hours, making the clinical decision making much easier. Okay, so in this particular case of a child with 1 or 2 factors in the middle risk group, observation is a particularly great strategy. And if they looked good for several hours in the emergency department, they could be sent home without imaging. In our second child, here is a 5-year-old who fell out of a tree on her head. She didn't have any LOC. She did complain of a headache, which she said was mild. She had vomited. But importantly, this child has von Willebrand's disease, or a condition which might increase her risk of bleeding. And is that going to change your approach to the evaluation? So in terms of the PCARN rule, you'd have to get some information about the tree and the height of the fall, but a severe injury mechanism for an older child is a fall of 5 feet or more. And let's say this tree, she had fallen from more than 5 feet or more than 3, it actually isn't feet, but is that about 3 meters or so of height from the tree? But should the coagulopathy that you have affect your decision making? So again, because the study was so large, they enrolled, and the PCARN study was so large, they enrolled 230 children who had underlying coagulopathies in the head trauma study. And they were able to look at whether the risk of clinically important traumatic brain injury was different in those with and without the coagulopathies. And so it was a variety of coagulopathies and other bleeding disorders, so hemophilia, von Willebrand's disease, thrombocytopenia, so ITP and other conditions, and then being on therapies that affected your bleeding and clotting time. And so interestingly, the kids that had these coagulopathies were much more likely to have a CT scan. Not surprising, right? That affects the rate of concern in the treating clinicians appropriately, but the rate of hemorrhage was actually lower in those that had coagulopathy versus those that not. That's hard to interpret because more kids are getting a scan but less injury. But overall, having these bleeding disorders didn't seem to dramatically increase the risk of actually having intracranial hemorrhage after minor blunt head trauma. So how should we affect in this case? We have a child who fell 5 feet from a tree who had von Willebrand's disease. I think we can use our clinical judgment. If they're well appearing with no signs and symptoms of a significant head injury while they're in front of you in the emergency department, observation without a CT is probably a safe strategy. If they are more symptomatic, then a CT scan is the right way to go. Okay. Our next case is a 2-month-old who fell off a changing table. No loss of consciousness according to the parent. They say they're acting normally, they're not vomiting, they're eating well, but there is a temporal hematoma on your examination. So in this child, it is probably appropriate to go right to imaging. A swelling of the temporal area makes you suspicious for a skull fracture, which is what I've shown here on the CT scan. On the soft tissue windows, you have the swelling of the area, and on the bone windows, you have a non-displaced isolated skull fracture with no intracranial hemorrhage. So what do you do? So you have a child who fell off the changing table with an isolated skull fracture. Is this a serious injury or not? And what we know is that the risk of clinical deterioration is very low in those children that have a skull fracture. In fact, we did a meta-analysis looking at all published studies of children with an isolated skull fracture led by Sylvia Bressman, who's a peds emergency physician in Padua, Italy. And that in that meta-analysis, we were able to include more than 6,000 children, and only one had clinically deterioration or required neurosurgery. So the risk is really low. However, in the US, there's a lot of these children that are admitted, and there's a lot of variability of care. So this graph looks at hospital level admission rates for isolated skull fracture by region in the country. But basically 80% of children are admitted, but some hospitals admit very few and some admit very many. And in all cases, none of them needed intervention during their time in the hospital. So just to say that isolated skull fractures are relatively minor injuries and probably do not require hospital level of care, but at least in the US, many of them are hospitalized, and it's a resource utilization we're working to reduce. Another thing to just emphasize the importance of thinking about non-accidental trauma. We're going back to our history. This is a 2-month-old who hasn't perhaps started to roll over, who's fallen off a changing table. So you're starting to think and assess, does that injury mechanism make sense for that child? It's an unexplained injury. The history doesn't make sense. Maybe you have one parent saying one thing, one parent saying another. Another red flag that I didn't highlight in this case, but if they're coming several days after injury, that's concerning as well. Or if they say that a pet or a sibling has been the cause of the injury, those are considered red flags for non-accidental trauma. And then Todd did a really nice job talking about the 10-4 facial score, which is really one of the best evidences we have around risk stratifying for child abuse. But in this case, we would want to examine that history and look for other injuries more carefully because that story is suspicious. And in my last case, we have a 6-year-old soccer player ran head-on into another player. There wasn't any loss of consciousness, but the child does have a moderate headache. They're complaining of photophobia and dizziness, and they maybe have some nausea, but they haven't vomited. Their examination is normal, although they may have some difficulty on balance. And this is a lot of what we're seeing in our emergency departments for head injuries. This is a sports-related injury, but kids fall downstairs and run into other kids at the playground at school. And of course, what this child has is a concussion. How you define a concussion, it's probably best to be broad, but the best definition that I've read is trauma-induced brain dysfunction. So this child would meet that definition. We don't need neuroimaging to diagnose a concussion. Neuroimaging is done to exclude other significant injuries, and concussion would be a diagnosis of exclusion when those concerns are mitigated. The treatment for concussion is actually relatively controversial. So the most important is symptomatic treatment, Tylenol for the initial, Motrin for the initial head injuries, nausea medicine if it's needed. There is good evidence that you want children who have concussions to avoid other trauma in the immediate period. So physical rest, avoidance of sports is fairly clearly recommended until they're cleared from their concussion. There's less good evidence and more controversy on whether patients should have also cognitive rest, and I'm interested to hear how you practice here in terms of how long you have them stay at home, do you allow them to look at screens, the rest procedures, because that evidence is a little bit more conflicted. But it is clear that before children return to sports, they need some clearance from a provider who can make sure that they have returned to baseline before they put themselves in other high-risk situations. I'll highlight one study that was done by a colleague, Ted Macknow, who works at the University of Massachusetts, and it's just a clever study around the cognitive rest. And so he did a randomized trial of patients diagnosed with concussion in a pediatric emergency department, and he was a relatively small study, only 125 children, but they were randomized to being allowed to have screen time, phones, computers, anything, yes versus no for the initial, I think 1 week after injury. And what you look here is a survival curve. We're used to looking at these for deadly diseases, but what they looked at was time to resolution of concussion symptoms. And the red group was the one that did not have any screen time, and the blue group was those that where screen time was permitted as wanted by the child. And at all time points from the injury, you see that the red group, the group that did not have any screen time, their symptoms were actually better. And so they showed a statistically significant increase or shorter time to resolution of concussion symptoms in those children that weren't allowed to use the screens, which does suggest some effect on concussion treatment, but a larger, more definitive study is needed. But a very clever idea that, that actually showed an impact. Okay, so wrapping up, we've talked a lot about head trauma. I think the PCARN head trauma rules are the largest and highest quality clinical decision tools that are available at this point in time. There's actually 2 rules, similar but different, one for kids less than 2 and one for kids that are greater than 2. Within those rules, those that have 1 or more symptoms, but who don't seem to be at high risk to you, observation can be a very important strategy. And so keeping a child, even just for a few hours in your emergency department, can really help you reduce the utilization of CT scans without missing important injuries. Non-accidental trauma should always be in the back of your head as an emergency provider. Does the story make sense? Is the mechanism consistent with what I'm seeing here? And the challenges that we face with all new evidence is how do we get it into practice? We know these rules, we talk about it in conferences. How do we remember it when the patient is in front of us, and how do we get it to impact our care? Because we see that translation takes time. So thank you, and we'll turn to questions.